Please remember that you should all be seated at the table on your red dot.
Like a or something.
No, the chime is too gentle. Everyone, please take your seats. You should now be seated at the table number on your red dot. There will be ample time for conversation at the tables, which you should now be seated at. Okay, everyone take a seat. You should now be at the table on your red dot. Okay, folks, I'm going to bring us back together. Okay. Perfect. All right, so now we should all be seated at the tables on our red dot. We are about to enter the first table discussion of the day. It is my pleasure to introduce our facilitator for this session, Dr. Jessica Freed, who is a resident physician at the Hospital of the University of Pennsylvania. Please join me in a round of applause to welcome Jess.
Hi, everybody. Thank you so much, Charlie. There's nothing more difficult than getting a room of engaged people that have been caffeinated to refocus and come together for a few moments of quiet. So I'm just going to go over the instructions for the table session. I want to make sure everybody has plenty of time to actually roll up their sleeves and do the work of discussing these important topics. So as Charlie said, you should be at a table that corresponds to the red sticker and the number on your red sticker. If not, just go ahead and casually move after this portion. No one will blame you. So just as a reminder, this is an opportunity for open, honest conversations to explore with colleagues what we value as healthcare professionals, how to change culture by focusing on human connection along the productivity and efficiency, and identify links between the learning, clinical care, and practice environments to improve well-being. So you'll have 30 minutes, and before you get started, you'll need to identify 3 people at your table for the following roles. You're going to need somebody that's a timekeeper. So we have 4 questions to discuss over those 30 minutes. So that person is going to keep everybody honest, moving on when you need to discuss the next question. You have to identify a recorder. So somebody should be taking notes in font large enough for everybody to see on those flip charts that are in the middle of your table. So pick the person with the nicest handwriting. And then you're going to pick a reporter. So the reporter is going to, at the end of all this, we're going to have a report out session, and we'll pick a few tables to offer their thoughts after the discussion that you have had at your table. So make sure you identify somebody now that is going to be the spokesperson for your table. So as we move into those 30 minutes of discussion, I'm just going to read the 4 questions aloud and let you all get discussing. I think the questions are printed in the briefing materials, but are also will be displayed here on the screens around the room. So the first question is, what do you value most in the clinical learning environment? And probably why. How do we connect with each other to preserve humanity in the clinical learning environment? And how does this impact the clinician? How does the creation of the ideal clinical learning environment benefit the clinician-patient relationship and ultimately the patient? And finally, what are the enablers and the barriers to creating the ideal clinical learning environment? So please discuss over the next 30 minutes, and then we'll bring everybody back together for the report out part of the session. All right, we can bring our individual conversations to a close. So for the next portion of the session, we're actually going to have a few tables report out. As you can see, there are far more tables than there are hours in the day. So what I'm going to do is ask 8 tables to come up and share their thoughts. Just in the sense of fairness, I actually used a random number generator to figure out which tables are going to be called up. Please rest assured that the flip charts are going to be, the notes that you've taken on the flip charts are going to be saved and collated. So all of your wonderful ideas will be saved in posterity's sake, even if you don't get to come up and report out. So the tables that I'm going to ask to send spokespeople up are 16, 2, 19, 17, 12, 10, 9, and 4. So if I listed you, please come to the front. And while they make their way up, I'm going to read some comments from the remote users. So in terms of what do you value most in the clinical learning environment, one of the respondents said, opportunities for bidirectional learning, students bringing new and current research and ideas, and skilled clinicians supporting integration of info into clinical care. How do we connect with each other to preserve humanity in the clinical learning environment? How does this impact the clinician? And somebody said it starts with the belief in the inherent value of each human being, regardless of what they know, think, or believe. How does the creation of the ideal clinical learning environment benefit the clinician-patient relationship and ultimately the patient? And somebody responded, when people are able to be vulnerable and authentic, safety follows. And finally, what are the enablers and barriers to creating the ideal clinical learning environment? And somebody just said transparency, simply. And so we'll go ahead and get started. A few reminders, everybody that's still in the audience, could you please take your flip charts and lay them down because the cameras can't see past them, so if they're doing any panning, you can lay those down. And then in terms of the report out ground rules, I'm going to ask that each of you only speak for 3 minutes. I know that's short, but just so that we can get as many ideas out there as possible. And what I'll ask you to do is please be actively listening to the other people presenting. If your idea gets stolen by somebody else, it's absolutely okay to just affirm and say, I agree with them, and share any new ideas that you have. But our goal is to share new ideas and not to have 8 people repeating each other. So, and we recognize that there's going to be a lot of common themes. So we'll go ahead and get started down here. And is there a microphone that I can hold for people? Oh, can you actually come up to the lectern?
Did you want us to talk about all 4 questions?
So you can choose to talk about whichever you feel most passionate about or your table felt most passionate about. You probably don't have time to talk about all 4 questions, so choose where your passion is.
That's great advice because we definitely deviated from the 4 questions. So my name's Tina Shah. I'm representing table 9, the best table. So I guess I'm going to start with question 1. And what really kind of came out with our discussion was actually a focus on the patient. So we spent probably a few minutes in the beginning just actually talking about our experiences either as a patient ourselves or being the person right next to our loved one who is the patient. And I think that was a good way to kind of frame what came out after that. And one of the things we talked about was true team-based care. And this is where we deviated a little bit because then we started talking about what is being called team-based care, which actually isn't, which is a bunch of different people coming into the room, and that's being called team-based care. But what we really want, and we've experienced from time to time, is when a team is truly coordinated, so you get asked that question once and not 15 times. And we felt that embodied kind of an ideal clinical learning environment. We also thought that having a safe space, and that's created by the faculty, our peers, and even other folks in the interdisciplinary team was crucial and a key aspect of what would be an ideal learning environment. And so someone gave an example of when your attending actually talks about things that they're struggling with, and maybe it's balancing childcare with being on rounds or something that's just personal that anyone could potentially be grappling with, that kind of broke the barrier and allowed everyone to say, okay, they're human too, I'm human. I'm not a robot. I'm not going to be perfect every day because that's just not possible. Do I still have a minute, or am I good or done? Or I'm done. All right, thanks.
Good morning. I'm Barry Rubin. I'm a vascular surgeon from Toronto. So we thought what was most valued was human-to-human connections. And that actually dipped over into answering the second question, which was how do we connect with each other? And we relayed a story of starting all interactions, meetings, rounds with spending a second and just saying something about yourself that had nothing to do with medicine whatsoever, because then you're interacting with a person, not somebody who is playing a role in the healthcare environment. And a really great example was when you page somebody and the answer, and they say, this is orthopedics, and you say, no, this is not orthopedics. What is your name? Because those are two very different things. So we thought that it was really important to fight depersonalization and to identify yourself as a person and not as just as the role that you're playing. In the creation of the ideal clinical environment, we thought that it was really important to create what this was referred to as a safe space. It was called a cocoon, so that people feel safe telling you their most personal stories, telling you about what's impacting them in terms of how their healthcare is being provided, and seeing you as a person, not just as the scary doctor or nurse in the white coat. Maybe I'll stop there.
Hi, I'm Pam Cipriano. I'm a nurse, the past president of the American Nurses Association, and my home organization is University of Virginia. So our table actually jumped into the assignment to answer all 4 questions. Some of the similar themes, though, was that we really believe that an important part of the environment is creating the relationships that allow team members to work together, to support each other, to value the interaction with their patient. Along with that goes something as similar as, again, introducing yourself with any interaction. Also making sure that there is a high value on diversity within the team, and that to match that to the respect that we have for our patients. Similarly, in terms of again, looking at enablers that also relate to a theme like diversity, to be able to address our implicit and explicit biases, so that within that care environment, we are acknowledging that. We also talked about the opportunities for being able to have good collaboration. Again, that safe space, the freedom and safety to be able to speak up, to give critique to one another. So also to be able to have mentorship within those relationships, and make sure that we are also respecting things like autonomy. We also talked about having sufficient material resources as well as human resources as well as time. Time came up on numerous occasions, as did the financial resources and support from other leaders in the organization, particularly like the C-suite. Recognition and gratitude. Again, trying to figure out how do we also help team members feel appreciated, be able to optimize their contributions within this environment that values the individual, but at the same time allows for sharing among different groups. We talked on several occasions, again, about safety, the improvements of safety for patients and their outcomes because of effective work environments. And then we also talked about, again, how important it was to have safety within that team, so that we were building trust as well as respect. In terms of just a few last comments in terms of enablers, again, we thought that we needed a shared vision. We need to have technology that was supporting the delivery of care and not disrupting it. Making sure that our teachers are well trained, and addressing the barriers such as incivility, tradition that drives poor decisions, resources, complacency, and the workload complexity and compression and overemphasis on productivity. Thanks.
So I'm Alex Amaya from the Association of American Medical Colleges, and as I was listening to Pam's presentation, I noticed that she had about 6 or 7 pages of notes. So her table did an impressive amount of work. So in terms of value, folks at our table talked really about the relationships in the team environment, such that members of the team had each other's backs. So there was a shared appreciation of all the value that the team members brought, but also a feeling that if there was a deficit in any area, that there was someone that they could turn to for assistance and help. that there was a knowledge transfer through a growth mindset and with free flow of communication and appreciation of teams. We talked about the importance of having a sort of a framework that allowed this to happen. So in other words, a structure and policy and rules perhaps that really describe how the team functions. And so that folks had something to look at too and understand when they first joined the organization about how teams work and integrate together. We talked also about potentially having a teaming, a thriving and improvement meeting rather than the MMI, or in addition to the MMI rather, focusing on really the space for creating the teams. We talked about the challenges of time. So how do you create these strong relationships if you don't have the time to engage, in that? Another important theme was that this really had to be patient-centered, focused on improving and dealing with patient care, and focus on the patient transition rather than the transfer of patient, but ensuring that there was patient movement that was covered by all the team members. So there also needed a barrier that was mentioned was there needs to be accountability, and so people understanding that they need to be held to sort of the standards, and we heard about some of those examples this morning. And I think that was about it for our discussion. Did I miss anything? Thanks very much.
All right, good morning. I was nominated by my team against my will to come up here and talk again. So just to, touch on a few things. To start off with, some of the values that we saw were very important to a conducive and a professional learning environment. Safety, honesty, integrity, a free flow of communication, as he just said, from top to bottom, creating a safe space where everybody can contribute to, the discussion and the embetterment of the team. And also a great point was brought up that your values are based off of your physical clinical learning environment. Some of us are in much different environments than other people, and to base those values off of, ultimately where you are is kind of the first step in terms of, determining the values needed to better your team. And then as we move on, we talked about, in establishing these ideal clinical learning environments, how does that benefit the patient-clinician relationship and ultimately the patient? It drives better patient outcomes. As we said, reduce costs, turnover, things like that, decrease harms events, and it allows us as clinicians to prioritize self-care. A lot of times with being providers or caring for others, we lose sight of caring for ourselves, and we cannot, optimize our patient care if we're not taking care of ourselves. Protecting our time or protected time, meaning not overstepping our boundaries as clinicians, to respect, people's time and things that they have to do outside of healthcare to maintain, their energy and things that they need to do in the workplace to make things happen, or increase efficiency and things like that. And to close out, we talked about a few barriers and enablers to these learning environments that we're here to talk about. Of course, time limitations would be a barrier. Hyper-professionalism, as we called it, a space in which, we feel that we cannot talk out, we cannot speak on things that need to be spoken on, hyper-professionalism, leadership turnover, and then some of the enablers, accountability, top to bottom accountability, where the resident is able to speak on some of the things that he or she feels necessary for change to happen in order to improve these learning environments, and also for the manager, for the chief director, to be receptive to some of the things that are said, So those are just a few things, and hopefully I didn't run over the time. But yes, thank you.
Hi, I'm Lindsey. I'm a general surgery resident from the University of Chicago. I'm representing Table 19. And kind of just to go back what you were saying, Jessica. We had a lot of the similar themes, so I don't want to spend too much time, but some of the things that we also noticed that other people mentioned were this idea of a safe space, that we feel like a good clinical learning environment is one that rewards curiosity as opposed to reprimanding or squashing it. So definitely we agreed with that point. We also really liked the idea of relationships, the idea that in order to have a good clinical learning environment, you need to have support. This idea being kind of like this Maslow's hierarchy of needs, that if you don't take care of yourself and you don't have good relationships and people that you can talk to and vent with, you can't have a good relationship with your patient. You can try, but you're going to lead to things like burnout a lot faster. So really, we spent a lot of time talking about enablers and barriers, and one thing that we thought was both was the idea of feedback, that a good clinical learning environment, you need to have good feedback, structured feedback that allows you to take constructive criticism and actually use it to improve yourself, because I think we all know in this room that feedback can be not constructive and not helpful and also lead you down the wrong path. So that was one thing we mentioned. And then another enabler of a good clinical learning environment is good leadership. So we talked about how every learning environment is probably going to be different in terms of how it best supports a resident or any other clinician. But what really needs to happen is for when there are issues or when there are problems, for leadership to be responsive and to make changes. Because we really felt like a top-down, trickle-down effect of changes is what's going to impact a clinical learning environment. So thank you.
Hello, my name is Dr. John Clark. I'm a simple country doctor from Salinas, California, representing Table 4, which was an amazingly diverse group of people. We had spiritual practitioners, we had a pharmacist, we had a surgeon, we had primary care doctors, anesthesiologists, policymakers. It was an amazing group to be part of. Many of the themes were the same. I just want to highlight a couple things on what we value most about the clinical working environment was the idea of a supportive teamwork and collaboration. This idea, the Dr. Humphrey's example of the fear of the medical students, like I'm going to hurt somebody, kind of speaks to somebody who's like, I'm going to be out there by myself and I'm going to make a mistake and I'm going to hurt somebody. And a learning environment where really it's like, it's not you, you're not by yourself, it's us, it's this team, we got your back. One of the physicians shared a story about her attending, they were doing surgery and the attending said, really, you're fine, keep going, you can't get into any problem that I can't get you out of. So let's go, you're going to do fine. So the idea that we got your back, this is a group, we're all in this together, it's not just you, that was really important. In sort of what we value in a learning environment. As far as how we connect and remain sort of human in that environment, the idea of being humanism is compassion, is our passions, it's emotions, it's how we connect emotionally. It turns out the work of medicine is highly emotional. There's tons of emotions running around. Most people don't talk about them. For us to connect with each other, we need to be connecting on that emotional level. Those clinical emotions need to be part of our discussions. Not only, wow, I just love doing my job, but wow, that was horrifying. Did you see what just happened to that guy? That's amazing. And I'm afraid of some things happening here, and have that sort of level of deep human connecting at that emotional level as well as the intellectual level. Also important in that was not making assumptions about people. So, if somebody says something, don't assume, well, that guy's really a jerk for saying that. Say, yeah, could you tell me more about that? Because I don't understand what you're saying, and really being open and aware of our biases, and that's a way that we connect with each other. And then the last thing I'll just highlight, when it came to barriers of care, the punitive environment came up as was important as a major barrier to care, but also the sort of industrialized environment of medicine, where this sort of feeling like there's a machine with cogs, you're an interchangeable cog that will go into a place that somebody had before you and somebody will come after you, and there's really something impersonal about the whole thing. And it's just this, we're moving forward with this kind of industrialized medicine thing, and there's no sense of connection, this kind of mechanized way of feeling like you're part of that. That was a barrier to care as well.
Hi, Hi, my name is Cha-Cha Chang. I am with the CDC, NIOSH, National Institute for Occupational Safety and Health. I represent table number 17 over there. Going last, I'm not going to repeat the things that people have already said, and I'm just going to point out the things that I think we haven't mentioned. We talked about the importance of humanism, that is relating to each other as human beings, recognizing each other's strengths, having the intention of communicating with each other as people and not just as clinicians, embracing failure, recognizing that we are vulnerable, sharing our vulnerabilities, and having leadership commitment and leadership setting an example of all of this. And we talked about the importance of empathy, but we recognize the challenge of compassion fatigue. So we talked about giving each other permission to have small doses of compassion so that you don't have to worry about the slippery slope where you just are overwhelmed. Barriers to all of this is that people may not feel like they have the skills to respond when their colleague is opening up, or they just may not feel like they have the confidence to deal with that. And people need to have resources when they do recognize that they are having challenges. But we think, despite the barriers, it's all worth it because in the end, the patients will benefit. This will help them feel more valued. It will increase trust and communication, which will certainly improve patient care. There would be more openness in the relationship with colleagues and in the patient-clinician relationship. And by allowing people to share their vulnerabilities, share with each other who they really are, they can open up the brain space, open up the energy and the resources to then focus on the patient care. Otherwise, there's a part of them that's sort of always distracted, thinking about all the other things that they can't share with other people. And we think that, sorry, there's one more thing. This, of course, build better relationships and improve the overall care for patients.
So thank you to all of our reporters today, and I'm sure that there were even more wonderful ideas that are floating around out there. At the end of the session, probably at the end of the day, the staff will collect all those pages so that we can kind of collate them and keep them together. I'd like to close this session by sharing a personal story and also some reflections on some of the things that I've been hearing in the room. So when I was a third-year medical student on my medicine rotation, it was a pretty tough rotation. You actually worked more like a sub-I. You did your own admissions, had your own pager, all this stuff. And I had like 8 weeks of it in a row in San Francisco, because we do some of our rotations in San Francisco at my medical school, which was Dartmouth. And I had this one patient, and it was my first patient that was going to die. Like you have those patients, and now that I'm older and have done more medicine, I realized no matter what you do, some of those patients are just going to die. And so she was going to die. And we had a family meeting with the husband, and they were in their 80s. They had lived together for 60-something years. And during the family meeting, we kept trying to steer back to, this patient's sick, she's going to pass away. And he kept talking about the wonderful 40 years that they shared together. And I'm getting verklempt right now, but so, and I'm leading the family meeting and all that, and he actually had pictures and showed us, and I cried during the family meeting. And, we wrapped it up, and he seemed to understand that his wife was going to pass, and he left the room, and it's me and the intern and the senior resident and the attending physician, and the attending turns to me and goes, "Is there something wrong with you?" And I was so taken aback that I was like, is I naked? Is my fly down? I said, "What do you mean?" And he said, "You cannot do that again. You cannot cry in front of a patient again." And I was like, okay, feeling a little sting, from that. And I went in the bathroom, cried some more. And the patient died, I think about 4 or 5 hours later. And I was in the middle of doing another admission in the ER. And the nurse paged me. And the nurse said, her husband wants you to come to the bedside. And so I went up, and he just asked me to sit with him. So I did. And I still cry in front of rooms full of people or in front of patients, because that's what proved to me that it matters to connect with your patients, even if an attending is going to be a jerk to you. But not all residents might feel that way. And so I think what we talked about today is that we have a huge opportunity to foster relationships and inherent shared experiences, whether that's sharing vulnerability or policing ourselves and making ourselves accountable to create that safe space or the cocoon that we talked about. It's easier than you think, even if you don't have resources like time or money. But if we all stand up and have that personal leadership to say, this is okay, it's okay to feel this way, it's okay to feel overwhelmed, and it doesn't have to necessarily be any admission of weakness, just normalizing feeling like crap can be good enough to make it a safe space and to make it a cocoon. I think that we'll be a whole lot better off to solving this problem. And yes, we still have a lot more things to talk about today, but thank you for everybody sharing their thoughts.